Hi, Dr. Barbiero. I'm going to be presenting for you necrotizing enterocolitis because we weren't able to do it during my rotation. Um, I was pretty unsatisfied looking up enterocolitis because I couldn't really find any main root causes for it or systematic ways to treat it. So hopefully this will help out a little bit. And I'll ask again on Sunday with the other attending how it's done in the ICU. So what is it? It's an ischemic necrosis of the intestinal mucosa. There's inflammation, enteric gas forming organisms, dissection of the gas into the muscularis, and possibly the portal venous system. It takes place in about 1 in 1,000 births, and it's about 7% of NICU admits across the country. It's more frequent at early gestational age. 13% of the cases are term infants, so it is important to be able to watch out for that as well. I'll be on Well Baby next, so I'll hopefully be an expert for that. Though these term infants usually have predisposing conditions like congenital heart disease, RDS, sepsis, are anorexic, polycythemia, etc. So clinical presentation, there's a grading system to identify necrotizing enterocolitis. It's the Bell staging criteria. So briefly, it's organized into 3 main parts. 1 is for suspected, 2 is for definite, and 3 is for advanced. So those are the severely ill or those with perforated bowel. And briefly, the way to tell them apart is based on either systemic or abdominal signs. So the systemic signs in order of severity are temperature instability, apnea, bradycardia, and lethargy, and those are just generally signs of sepsis or disease in the neonate. Moving on to the definite, stage 2, there's mild metabolic acidosis and thrombocytopenia, and for the advanced, also includes hypotension, bradycardia, respiratory and metabolic acidosis, DIC, and neutropenia. Abdominal signs in order: gastric retention, abdominal distension, emesis, heme positive stool, pardon my dog in the background, and grossly bloody stool. More advanced is absent bowel sounds or an ileus, with or without abdominal tenderness. Next to the more severe, cellulitis in the abdomen or right lower quadrant mass even. And finally, an advanced severely ill child would have signs of peritonitis, marked tenderness, and abdominal distension. So that's a lot. And it seems pretty hard to be able to distinguish a child who's generally sick with this necrotizing enterocolitis, which has a pretty rapid course of deterioration. And I would like to know what would tip you off other than the distended abdomen, and how quickly these bloody stools can occur. I mean, that's the most obvious one that you'd want to start the process. So for the diagnosis, there are 3 main criteria that you can do to automatically, or that you can use to automatically diagnose. That would be abdominal distension, like I said, the rectal bleeding, and the pneumatosis intestinalis. So the ways to do that, the ways to examine that you can use at your disposal are radiograph, ultrasonography, and blood tests. For radiograph, remember you'd always want to treat with a suspicion, so you don't necessarily need the radiograph to start treatment. You'd obtain serially to follow the disease course, as it can go pretty quickly, so about every 8 to 12 hours. You'd notice an abnormal gas pattern consistent with an ileus, the pneumatosis, bubbling of gas in the bowel wall, pneumoperitoneum, or like the football sign, so leaning on the back, taking a sideways radiograph, you'd see air in the abdomen, and you may not even need a radiograph for. Ultrasound, I was doing some research in. It doesn't sound that sensitive. Maybe you could see some gases better without exposing a child to radiation, but if you're worried about this, I think it's okay to subject them to a few x-rays. Blood tests, you'd want a CBC, and you could diagnose it with white blood cell less than 1500, or even greater thrombocytopenia. Um, Coag studies, you use this if one, you suspect DIC in severe cases, also for surgery, which they may end up needing in the standard BMP, PH, ABG, if a respiratory compromise occurs. And this, by the way, the respiratory compromise could occur just from this pneumoperitoneum or ascites pushing the baby's lungs up. I should note that in a workup, never give a contrast enema, because that could lead to bowel perforation and extravasation of the contrast, which is bad. Don't do it. So I couldn't really find any standard flow chart of how to make it happen in the NICU. And so I think I'm imagining every physician is different. And the differential things that you should consider are the pneumatosis coli, which is a rare benign type of NEC, I suppose, but it's just gas in the abdominal and the intestinal wall that resolves spontaneously. Any bacteria that causes bloody bowel movement, like Campylobacter, C. diff, Salmonella, Shigella, you should at least consider in the differential. And you can ID stool culture, but I've never seen a stool culture that wasn't a complete disaster with all sorts of bacteria in it anyway. Anatomically, it's Hirschsprung's disease, ileoatresia, volvulus, meconium ileus, and intussusception. Some kids could just have spontaneous intestinal perforation, or terminal ileum, like in a terminal ileum, which would actually end up, you'd have a somewhat similar treatment to this. And also, an anal fissure could cause bleeding. So medical management, I'm sorry if I'm going up towards 10 minutes here. Medical management for supportive care, bowel rest, GI decompression, NG suction until the ileus resolves. TPN and a central venous catheter, possibly, not necessarily. The TPN would come later, it's not an immediate concern. Fluid replacement for the third space losses, cardiovascular respiratory support, as I said before, and you can correct the hematologic and metabolic abnormalities, so you can give bicarbonate for acidosis. Antibiotic therapy, there's no consensus regimen, but some suggested include Vanc plus Gent and Zosyn. The Zosyn for the beta-lactamase enterics and anaerobes, Vanc for staph and strep, and Gent for synergy for the vancomycin. Others could use instead of the Zosyn, use metronidazole, clindamycin, or some third generation cephalosporin. Usually you could use any of these regimens for 24 to 48 hours until cultures return. If cultures are negative, keep only the Zosyn if you go with that route, only for at least a 14-day course. And I should note that only about 30% of patients end up having a positive blood culture, and I'm not sure exactly about the fecal culture. Surgical management, you always, well, at least according to these studies, who were probably written by surgeons, you always want to have a consult called in immediately for evaluation. Perforation always equals surgery. The procedures, there's two main procedures you could do, the XLAP with resection, and the second is primary peritoneal drainage, which I'm not familiar with. And this can be done at bedside in the NICU, which basically involves irrigation with saline, and it's done at McBurney's Point, and you leave in a Penrose drain. So complications, I promise I'm almost done. There's some late complications. Strictures, so usually occur within 2 to 3 months, but can happen anytime after surgery. And these strictures may cause repeated infections, bloody stools, failure to thrive, and obstruction requiring further surgery. And it's suggested that you give contrast enemas 4 to 6 weeks after the resolution of the neck. Short bowel syndrome, which would occur with the resection, which could lead to malabsorption, fistula, and abscesses, the general surgical problems. With this malabsorption comes the worry of various neurological problems down the road. and there's a lot. It's studied quite, I wouldn't say quite well, but there's the great possibility that with a short bowel syndrome or just any problems with the bowel at a very young age could lead to various developmental problems. It's listed that about half of the children have a good outcome, I don't know how far that goes down the road, and what the criteria was for neurological improvement. I think that's it. Okay, thanks for listening.